Hi, this is Junaid with Acute Ischemic Stroke 2000 guidelines. In the last three sections, we discussed the treatment, the evaluation of acute ischemic stroke patients, and then discussed TPA and mechanical thrombectomies. In this particular section, we're going to move to section number 4, which deals with in-hospital general supportive care of patients of acute ischemic stroke. So we're going to discuss all these factors in two different lectures, and we're going to start with stroke units. What we have seen that if you have made a stroke unit, one of the key things that really help is that everyone is geared towards rehab and making sure that the patient gets all the support it needs. So social workers line, the PT, OT, ST, and everything is inbuilt within the system. So it is highly recommended that stroke patients are taken care into a stroke unit because these standardization and availability of resources do help. Similarly, using order sets, there is no delay that you have to get a call, can I order physical therapy? It is ordered. Patient needs to be evaluated. Anyone that is coming with acute ischemic stroke that needs to be evaluated by physical therapy and occupational therapy. So again, it's the using of standardized order sets and putting in the patient in a stroke unit is definitely improves outcome, and therefore even the level of evidence is not that great, especially for order set, as you can see. But definitely stroke units do improve outcomes, and hence the class of recommendation is 1. Now let's move to head positioning, laying the patient flat. The concern, the risk and benefit here is that, the chances of patient getting hypotensive, the patient actually continues to get great cerebral blood flow has to be counteracted with a consideration that the patient might have dysphagia and can have aspiration pneumonia. So in short, the data is uncertain. The class of recommendation is very weak. It's 2B. I generally don't do that. As a matter of fact, more importantly for me is that the head position is actually straight and it's not tilted. So therefore, the patient actually has, continues to have good cerebral blood flow, both with venous drainage size and arterial flow, rather than actually the head of the bed. In my regard, generally, we do not do flat head positioning of the patient. Of course, take care of the airway, need ventilation, do it, give supplemental oxygen if need be, and then hyperbaric oxygenation is not recommended, nor is, putting extra, for no reason, giving them oxygen if they're not hypoxic. There's no point in doing that. Now, blood pressure goals. Hypotension and hypovolemia should be avoided clearly. Those are really one of the biggest factors for, in my opinion, preventable early neurological decline. There's no good data around it clearly, but the class of recommendations that you can see is very high. And in those patients where they're very hypertensive and they have comorbid conditions like, congestive heart failure, symptomatic small intracerebral hemorrhage, aortic dissections, maybe eclampsia, preeclampsia, whatever that situation may be, you should treat that hypertension appropriately. So you have to decide hypertension on the terms that the patient is actually, what your patient actually requires. Now we come to blood pressures. So we're talking about blood pressures in two categories. If it is non-IVtPA patients over here, we're not talking about post-TPA patients. We're only talking about those who did not receive TPA. There are two categories. One is above 220 and one is below 220. Those patients who are above 220, treatment with antihypertensive medication doesn't improve outcome. The short answer is we don't know the data. If we don't know, then it is a weaker recommendation to treat it. And then treat it appropriately according to your patient's comorbidities. If the patient actually has severe CHF, has an NSTEMI going on, you're going to keep pursuing severe permissive hypertension of leaving the systolic blood pressures up to 220? No, you can decline it to 200 and then consider seeing what the patient does. And if it's not hemodynamically significant, then you can consider even moving a little more forward. What they're suggesting over here in the guidelines is that do allow permissive hypertension, but take into consideration patients' comorbidities. And that those patients who already have a systolic blood pressure less than 220 and requires urgent antihypertensives within the 48 to 72 hour window, go ahead and then do it because it doesn't really prevent stroke or death. So if you have a situation where patients actually need to have a lower blood pressure, go ahead and do it, especially after 48 to 72 hours. And the goal is within the first 24 to 48 hours, you keep the blood pressures with a permissive hypertension, then start declining by 15% per day. Temperature Another thing with all neurological problems, again, the data has been very, it's not from an RCT. So clearly we don't really have a good level of evidence, but it's very clear that hyperthermia can cause bad outcomes. You should use antipyretics, try to minimize hyperthermia as much as you can. Hypothermia, to date, I haven't really seen a good study, a randomized control trial that can actually prove that it has a good outcome. And one of the reasons is not that it does not provide a good neurological outcome. I think it does. The problem really is that it causes a lot of risk with coagulopathy, further deteriorations, pneumonias, etc. That all the recovery you get from hypothermia is actually drowns out with the risk. And that's why we are looking forward one of these days to have localized hypothermia of the brain, and that might actually help. Till that time we get that, there is no recommendation for induced hypothermia. Now, avoid hypoglycemia and hyperglycemia in those patients, especially hypoglycemia. If the patient is hypoglycemic independently can cause mitochondrial decline, and they can act as if prolonged hypoglycemia is equivalent to having an anoxic brain injury. So on top of stroke, you do not want that. So definitely make sure the patient is not hypoglycemic. And hyperglycemia control should be 140 to 180. It should not be too tight. And the reason behind not too tight is to prevent having hypoglycemic events. Again, I'm very grateful for your time. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.